Good morning friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order. I hope this will be very convenient for the continuous study. My dear friends, we have been discussing about bleeding and clotting disorders. In the first part, we have seen the basics of bleeding and clotting disorders, coagulation profile, its interpretation, etc. Second part, we are discussing about one of the disease of the intrinsic pathway of the coagulation cascade. So that is hemophilia. We are discussing since last 2 or 3 classes. So hope today will be the last class regarding this hemophilia. In the last class, we have covered up to the treatment portion. So today we shall have some of the important other factors and as well as some of the case studies. Yes, prognosis of the hemophilia in the last class we have seen, but some of the other rare problems related to hemophilia we have to discuss, that is factor 13 deficiency. Now factor 13 is the last factor and this is also called as a fibrin stabilizing factor. Okay, once the clot is formed, to further stabilize that clot, so usually factor 13 is required. Okay, so sometime deficiency of this factor 13 may also lead to some of the problems. So there will be delayed hemorrhage due to instability of the clot, because this factor is basically related with the stabilization of the clot. So once it is absent, so there may be hemorrhage not immediately after the formation of the clot, but in the later part, because that clot is not completely get stabilized. So the patients have the trauma on one day and then bruise or hematoma on the next day or day after that. So that means after 2 or 3 days, patient will have the bruises or formation of hematoma. The injury would have been taken place 1 or 2 days back, but after 3-4 days, patient will complain of formation of the pain and formation of the hematoma. So when you get such cases, it may be because of factor 13 deficiency if all the other investigations are showing normal results. The delayed separation of the umbilical cord stump beyond the 4 weeks, and there will be a poor wound healing. That means if you want to diagnose this particular factor 13 deficiency at the earliest, then delayed separation of the umbilical cord stump, that is, cord is separated usually by 7 days and completely separated and get dried up by 10 days. And the umbilical, that stump wound will be also almost all clear by 10 days. But if there is factor 13 deficiency, the separation of the umbilical cord from the stump itself will be delayed. And how much is delayed? Beyond 4 weeks. Okay, usually it will complete by 10 days, whatever, but it takes about 4 weeks, 28 days. 4 weeks or 28 days, and there will be poor wound healing. So usually the stump wound, ulcer like stump wound will be there, so that will be healed within 1 or 2 days. And if factor 13 deficiency is there because of the continuous oozing of the blood or whatever, instabilization of the clot, that wound will not be properly formed. It will take a prolonged time for the healing. Same problem in women may lead to recurrent spontaneous abortions. Okay, in the women there may be recurrent spontaneous abortion and you investigate for everything, you didn't find anything. At the end there may be factor 13 deficiency. This is also the possibility. And this is usually normal screen, because in factor 13 deficiency usually all the normal screen test will be normal. Okay, so normal clot remain insoluble in the presence of the 5M urea, whereas in a patient with 13 deficiency the clot dissolves. This is one of the way how to identify this. Okay, how to identify in a normal clot. Okay, if you put 5 ml of urea on that, so that clot will be insoluble. Okay, but if there is factor 13 deficiency on the normal clot, if you put 5 ml of urea, then the clot will go into dissolve. So this is one of the way of identification of factor 13 deficiency. What is the treatment? Treatment is FRP or cryoprecipitate. So this is one factor 13 deficiency. There are certain other acquired coagulation defects are also present, which mimics like hemophilia and all other disorders. Number one is liver disease. If the person is suffering from liver disease, for example, because all the clotting factors are produced from the liver except factor 8, true hemophilia factor. So except that, all the other factors are produced from the liver, or one or the other way they are interrelated. So we have to give vitamin K 1 milligram per day in infant, usually immediately after birth, or 2 to 3 milligrams per day in a children, and about 5 to 10 milligrams per day in adolescents if there is a problem related to coagulation profile or coagulation disorders. Okay, desmopressin 0.3 microgram per kg IV can be also given. So this is one conditions where there will be coagulation problems related to liver disorders. Okay, so now another cause of acquired coagulation defect is vitamin K deficiency. This is only because of liver problems. The liver is not able to produce the coagulation factors. Now sometimes there will be only vitamin K deficiency. Okay, vitamin K deficiency. Now there are so many clotting factors which are vitamin K dependent. Okay, almost all the clotting factors are produced from the liver. Okay, but some of the clotting factors are like that, they are dependent on vitamin K. In the first case we have seen the liver disease where all the clotting factors are get affected except factor number 8. Another condition is acquired coagulation defect where vitamin K is deficient, and vitamin K is required for factor number production of the clotting factor like 2, 7, 9 and 10. Very important. They are vitamin K dependent clotting factors. So if the vitamin K is deficient, this is resulting due to the reduced synthesis of vitamin K dependent clotting factors. And see 2, 7, 9, 10. Now 10 is related to both pathways, intrinsic and as well as extrinsic. Whereas if you see 7th is also related to extrinsic, 9th is related to intrinsic, and 2 is related to mixed pathway or common pathway. So therefore, if vitamin K deficiency is there, you will have problems in extrinsic pathway, intrinsic pathway, and as well as combined pathway, common pathway. So PT is also increased, APTT is also increased, and mixed pathway presentations are also get increased. So what is the treatment? Yes, injection of vitamin K we have to give 1 to 2 milligrams per kg IV. Now in the newborn, why we are giving vitamin K immediately after birth is liver is immature and not able to handle the produce the clotting factors properly, and even the vitamin K production is also not yet produced. Vitamin K is endogenous also, endogenously it is produced, it is also produced not up to the mark. So by keeping all these things, there may be chance of hemorrhagic disorders in children, newborn. So in order to prevent that, precautionarily or prophylactically we are giving vitamin K injection. So one more acquired inhibitor of the coagulation factor like is seen in case of SLE. One more acquired coagulation problem, that is production of some of the inhibitors, especially in case of SLE, systemic lupus erythematosus, where lupus anticoagulant and viral infections in HIV. So there may be autoantibodies against the coagulation factors. Now SLE is an autoimmune disorder. There will be production of the autoantibodies, and some of the antibodies may be also produced against the clotting factors. So this may also lead to the coagulation problem. Now let us discuss some of the important cases. A 16-year-old patient, female from Bhopal, brought to the OPD with complaints of gum bleeding which is of sudden onset. There is past history of arthralgia and also occasional mouth ulcers. Okay. Now 16-year-old patient, Bhopal means any geographical distribution we didn't find. Gum bleeding is there, sudden onset. Okay. Gum bleeding, maybe there is some hemorrhages precipitated by the injury while toothbrushing, and it is of sudden onset. Okay. Now there is past history of arthralgia. She has got arthralgia. That means there is every possibility of getting hematoma, hemoarthrosis, etc. in the joint area, and also occasional mouth ulcers. Yes. Okay. Lab report says LFT and creatinine was normal. CBC and platelet counts and PT were also normal. So PT is normal means there is no extrinsic pathway involvement. Platelet count is normal means it is not a platelet disorder. But there is increase in the APTT or PTPT. 30% it is raised. So one thing is very clear, this is a case of intrinsic pathway. Intrinsic pathway means most probably hemophilias. Which type we have to see. Next day on the round, she gave a history of easy bruising and heavy menstrual bleeding, 16-year-old. So heavy menstrual bleeding since so many months. Yes, during the menstrual period there is shedding above the arteries, bleeding will be there, but it is not able to undergo clot coagulation, and therefore there is heavy menstrual bleeding, and there is no family history from the mother's or father's side. Okay, and she has undergone 2 minor surgical procedures in her life, like nail removal and tonsillectomy. Okay, previously has underwent these 2 surgeries, nail removal and tonsillectomy. During that time, if you get the history, there is no much bleeding took place. Okay. Now, if she has got the dentist or hematologist, is she has to go to a dentist or hematologist. Now gum bleeding is there, कहाँ पे जाना पड़ेगा उसको, डेंटिस्ट में जाना है, हेमेटोलॉजिस्ट में जाना है. And she is a bleeder and looks like a bleeding disorder because she is not only bleeding from the gum, she is also bleeding from the other sides of the body, like bruising is there, menorrhagia is there, almost all 3 sides. Suppose if she is only bleeding from the gum area, definitely she can take a consultation from the dentist, but it is not the case. She has got similar bleeding from the other parts also. Question is, this is a genetic disorder or acquired disorder? Yes, this is an acquired disorder because she is 16 years old and before that she has not giving the history of bleeding at all, isn't it? In tonsillectomy also and in nail removal also she has got no much bleeding. If she has got this bleeding disorder from the beginning itself, like hemophilia like conditions, etc., definitely the history will be there, but it is not like that. And since a few months the menstruation is heavy. Only since last few months she is complaining that menstruation was heavy, and now gum bleeding and recurrent mouth ulcers. And active bleeding from the gum started just first time before few days. So there is no problems with the 2 surgeries safely. So this gives a clue that this may not be a hemophilia, and child is also 16-year-old. And so far she has got not such problems, didn't got any such problems. What is the nature of the acquired bleeding disorder? Now, if this is the acquired cause of the bleeding disorder, platelets are normal and the extrinsic pathway is also normal. The problem is only with the intrinsic pathway, isn't it? So commonly acquired bleeding disorder is thrombocytopenia or thrombopathy or anticoagulation. Suppose she is undergoing any anticoagulation therapy, or if she is suffering from liver disorder, DIC like condition, vitamin K deficiency, uremia or acquired hemophilia or any autoantibodies, etc. Okay, now is it a case of thrombocytopenia? No, because in this patient the platelet count is normal. Okay, so in this platelet count is normal. So probably she is maybe suffering from some other vitamin K deficiencies or other liver disorders, or maybe as it's sudden onset the chance of autoantibodies is maximum. Okay, so this is a case of acquired hemophilia. Actually this is a case of acquired hemophilia because of autoantibodies, because the only thing which is favorable to the favorable to this diagnosis is a sudden onset. All the problems are there, but it is a sudden onset. So sudden onset may take place after the intake of some of the drugs, or maybe only autoimmune pathology. Liver disorder, it takes a long time to develop this. DIC also takes a long time. Vitamin K deficiency also takes some time. It's not a sudden disorder. Okay, so this is how we have to analyze. Let us go for the next case. A 20-month-old baby was being started with bleeding from the oral cavity, and boy had past history of bleeding from the umbilicus at 8 days of the newborn life, followed by frequent bleeding episode from the oral cavity off and on. 20 months old means almost 1.5 years. Okay, he had got a past history of bleeding from the umbilicus previously also at 8 days of the life. That means during the time of cord falling and all. Later he had got frequent episodes of bleeding from the oral cavity on and off. Now a screening test was done. HB is 8.8, slightly reduced. WBC is 9.9. Platelet is 2.96. All the 3 are almost all normal. Now prothrombin time, PT, is 57.8 seconds, and APTT is more than 200 per second. INR is 4.86. TT is 12 seconds. Now PT and APTT both are increased, no doubt. So HB is less because frequent bleeding may be the cause. APTP is prolonged, so there is intrinsic pathway involvement is there, either factor 8, 9 or 11th. And there is also increased PT, therefore there is also involvement of the extrinsic pathway. So we have to suspect the common pathway defect because both extrinsic and intrinsic both are get raised. So now suspect about the common pathway defects. Factor 2, factor 5 or factor 10 deficiency may be there, but TT is normal, so there is no factor 1 deficiency. Further clotting factor SA was sent, and in this factor 2 is 109%, factor 10 is 90% and factor 5 is 8%. So in this case factor 5 concentration is very, very low. Factor 5 is related to combined pathway. So in the combined pathway factor 5 deficiency is existing, and that is the cause of this particular bleeding. So this is known as a factor 5 deficiency, or also called as parahemophilia, or also called as Owen's disease. Now let us go to the next case. We have got case number 7, and thereafter we have the important disease to discuss, that is von Willebrand disease. So let us go to the case number 7. Case number 7, here a 2-year-old patient came with the complaints of trauma on one day, and then he developed a hematoma on the next day, and there was a delayed separation of the umbilical cord stump beyond 4 weeks. The platelet count, PT time and APTT and bleeding time were normal. Everything is normal. Okay. In the presence of the 5 mm urea, the clot was dissolved. So what will be the diagnosis? Yes, this is today only we have discussed. So this is on putting 5 ml of urea, the clot is dissolved. That means factor 13 deficiency. So this is, all the other screening tests are normal. Okay, so therefore it is factor 13 deficiency. So with this we conclude for today. Then tomorrow we will have one more very important disease to be discussed, and that is nothing but von Willebrand's disease. Von Willebrand disease, we cannot neglect this disease, very important disease, which is also called as vascular hemophilia and which is also called as pseudo hemophilia. So we will going to discuss in the next class. Thank you very much.